Well, I have 2 o'clock, so good afternoon. Thank you for attending the Telemedicine Echo focusing on telebehavioral health. The Heartland Telehealth Resource Center and Missouri Telehealth Network have joined together to offer this Telemedicine Echo, and we will be covering topics such as technology, operations, clinical, legal, and regulatory, as well as some evaluation. I'm Janine Gracie, Director of the Heartland Telehealth Resource Center, and I have the privilege to moderate these sessions. And I also want to give a shout out to all of you who are joining us who have been on the front lines. We appreciate you, and we know that you're very busy and that you're tired, and you might have some Zoom fatigue, but we're glad you're here, and we'll get started. Before we move any further, though, I would like to ask that you right-click on your picture or on your name, and then rename yourself, your first and your last name, and then what state you are from, because we have, since this Heartland is a region, we want to know what states we're going to be talking about and making sure that we have some representation from all of our states. So thank you for doing that. Now I'm going to have the hub team introduce themselves. So we're going to start today with the birthday girl, Rachel. Would you introduce yourself?
Hi, everybody. Rachel Mutro with the Missouri Telehealth Network and the Show Me Echo program. And I also work with the Heartland Telehealth Resource Center.
Okay, we can't not do this. Happy birthday to you. Happy birthday to you. Happy birthday, dear Rachel. Happy birthday to you.
And many more.
That was awesome. Thank you. Thank you. That was amazing.
Very good. Okay. So is that an echo first? That's fun. Tim, how about introducing yourself?
Yes, thank you. Good afternoon. I'm Tim Davis, Telehealth Manager at Oklahoma State University, and I work with the HTRC in Oklahoma as well.
And Heather?
Good afternoon, everyone. My name is Heather Hagan. I'm the Telehealth Analyst at OSU CHS.
Great. And last but not least, I think the last hub team member is Kristin.
Hey everybody, I am Dr. Kristin Sohl. I am a pediatrician at the University of Missouri, and my day job is as an autism specialist. I take care of kiddos with developmental disabilities, particularly autism, and I'm also the medical director for the Missouri Telehealth Network and Show Me Echo, and also the founder of Echo Autism. So happy to be here with you.
Great, thank you so much, Kristin. All right, since we have several participants today, we are going to forego participants' introductions. So what I'd like for you to do is to type in the Zoom group chat your name, organization, title, and the state that you are from once again. So if you would do that for us as we get started, that would be excellent so that we can meet you all. Let me see if there's anyone here on by phone. I do see one phone number, 267 area code. Would you like to introduce yourself?
Hello.
Yes.
My name is Hi, my name is Wan Ting Chao. I work in Parsons, Kansas, Acute Medical Surgical Center Department. Thank you.
Excellent. Thank you very much. We appreciate that. All right. Now, just some more housekeeping. For a more collegial environment, we'll be using first names today. And just want you to be careful with any kind of confidential or protected health information, so we don't share anything like that. We're probably not going to have a problem with that during this echo, but just wanted to remind you. If you look on your participant list, you can find Ask Joe Kingsbury. So he is going to keep track of our questions by chat. So if you have a question while the presenter is presenting, then just find Ask Joe Kingsbury, and he will either answer that question or he will be able to ask it when we do have our question and answer portion. So thank you for that, Joe. Please, if you want to ask your question, just unmute your microphone and raise your hand before you speak, and then ask your question. So also make sure you introduce yourself before you ask that question too. Keep those microphones on mute. That helps us out a lot with the audio so that we can have a nice clean audio. The presentation will be available in Box as indicated in registration, and case recommendations will be placed in Box for everyone to access too. The value of ECHO is in case presentation. So if you have questions, concerns, you know, a case for this telemedicine ECHO could be something like, we have a large clinic with an outlying clinics, and how do you suggest that we set up our technology, that type of thing. Okay, so you can ask those types of questions through a case study, and then we can all chime in and provide those recommendations. All right, so we are going to get right on into the didactic portion of our presentation. Dr. Sohl already introduced herself as the Associate Professor of Clinical Child Health at the University of Missouri. She is very well versed in telemedicine and is a hub member, of course, of our team. She's a pediatrician and interested in all things child, right? Yep. But she's going to provide us with some telehealth etiquette. And I think you'll really enjoy her presentation today. So Kristin, I'm just gonna give the Zoom to you.
Sounds great. All right, so I'm going to share my screen with you, and thanks for having me today. I'm going to talk about telehealth etiquette, and I have some slides to share with you. One second. I got some great help from my dear friends at the Missouri Telehealth Network. They shared some slides with me, and I made a couple of updates. So just wanted to kind of help everyone, you know, as we start shifting more and more to virtual visits, some more quickly than others, it's helpful just to think about what does it mean to do these visits, and are there some tips and tricks that can make them go more smoothly? And so we're going to walk through some of those practical tips or etiquette, if you want to think about them that way. And so we do have some objectives. I want to help us think about ways to maximize our use of technology, as well as learn best practice tips for virtual visits and discuss strategies to support patients after the visit. We're going to keep it pretty brief today, so I will have time to answer questions, and that this is not an all-inclusive discussion of tips and tricks for you know, implementing best practices, but I think it'll give you at least some things to think through as you are either starting your journey into virtual visits, or potentially you're old hat at it, but either way, hopefully it'll give you some strategies and ideas. So one of the first things that I like to think about is, you know, all right, so here we have these new technologies, and some of us, again, are doing this and have been doing this for a while, but many of you may not have been doing this from your home. So it's going to be important to practice, and you need to practice a couple of different key elements. So connecting, obviously, makes sense, right? Also turning on and off your audio. So muting or unmuting is what we call it in Zoom, but every little, you know, different platform may have something different. Same thing with turning on and off your video. All very important elements to think through. Also, thinking about your virtual clinic flow. So I know that this is something that as practitioners of virtual visits, this is important to think about. So especially if you're doing this to a patient's home from your home as the provider, these are things we don't always think about. And so I've been doing these visits to patients' homes over the last month since COVID-19. How does a patient get arrived into the system? I don't arrive them. So I've got to figure out how to communicate that to my staff, right? So what does that look like? How will I communicate with my office staff? Am I going to text them? Am I going to use an instant messenger? Am I going to email them? What does that look like? So all of these things, how do we maximize our technology and those skills to make those go well? Documenting. Are we going to document within the platform? So some people are using technology that's built into their EMR. I am not. So here at the University of Missouri, we're using Zoom, and it sits outside of our electronic medical record. I love it because I'm really well versed in Zoom and I know my EMR, so I don't have to learn a new system. But lots of people are using an integrated system. So what does that look like? And how will that affect your virtual practices? Working with learners. Some of you may be in an academic medical center, or you may be in community practice where you do still have learners coming into your clinic. I recognize that's probably not all that common right now. You're probably not accepting medical students into your clinics right this minute. But I know for a fact I still have students and residents, and so some of you may as well. So what does that look like? How do you introduce them through a virtual visit? How are you going to communicate with your residents if they go into a virtual visit first? What are your backup plans if the virtual visit gets disconnected and they need to get to you as the attending or the practitioner? How's that going to look, right? And so I can share fun stories about how we've done that over the last month, and actually have been able to troubleshoot that very nicely. But certainly important to maximize those skills and think about how you're going to do that. And then resource sharing. So another thing to practice is, how are you going to share the resources or the education that hopefully you would normally share with your patient about whatever that you would like to talk to them about. So if you're going to diagnose them with a rash, how are you going to show them, the education that you would typically show them? Or if you're, in my case, if I'm going to talk to them about a behavior, what am I going to, how am I going to give them the resources I would normally give them? I've found this to be the best thing about these virtual visits is I can share my screen. So I can show them right on the screen how to get to the website, how to show them the video I want to show them, how to do all that stuff that I would normally have to either hand them in a printed form or do some kind of interesting workaround to show them. But now together, I can walk them through that right then, right there. So it's actually been really quite fun. So that's a neat thing that's a benefit to these new virtual visits, but you got to know how to share your screen. So take some practice, very simple, but it's definitely worth practicing. Now, things to think about too, troubleshooting technology, important to know. If you're in the middle of a virtual visit with your patient and what happens? Zoom bombing happens. Now, what are you going to do? Okay, so thinking about what that means. This is a new term that frankly was new to all of us about a month ago. Maybe it was happening to others, but I'm not sure it was in our vernacular until about a month ago. So what this means is you might be in the middle of a Zoom session with your patient. And by the way, right now we're using Zoom pretty ubiquitously. It could be anything. It could be, it could be anything. Okay. But essentially what that means is somebody who's not supposed to be there pops into your screen. Let's hope they have clothes on, but sometimes they don't. And so what are you going to do about that? And here's what's important to know. If you're a clinician and that happens to you, you got to figure out how you're going to handle that and handle that pretty fast. The good news is that most of our technology virtual visits should be happening through HIPAA secure technology. But I am going to tell you that there are many places right now, because of the way that the current policies are situated, that you are technically able to do some of these visits outside of our current HIPAA standards. And so it is important for you to understand that this could happen. And so I just wanted to bring this up as something that you should be aware of. There are great strategies to avoid this, and I would encourage you to be aware of them. Your institutions should be aware of them too, but just in case they're not, I put them here for you. Zoom, again, using this term somewhat ubiquitously, but in this case specifically, has something called a waiting room, where me as the clinician only allows people in that I know are supposed to be there. So if it's my patient, I let them in. If it's my resident, I let them in. You can also password protect a particular session. You can also close the session. So once I'm in and the patient's in, I can close it so nobody else can get in. Those are ways that you can protect that sanctity, if you will, of that patient appointment. And those are important things for you to know about, because the last thing you want is to be caught off guard in the middle of your patient visit, especially if you're talking about something sensitive. Now, you also want to think about troubleshooting. This happens. This is going to happen to you. It's happened to me several times. How do you convert to an audio only visit or a phone visit? So the audio or the video goes down on Zoom, whether it's your audio connection or your video connection or theirs. What happens now? What are you going to do? Maybe you're in the middle of an important conversation about a diagnosis or an important conversation about a condition that they're concerned about, and everything just went down. Well, now you need to think about how you're going to connect. So there are multiple strategies. Obviously, if you have your EMR up next to you, you should have their phone number right there, so you can just pick up the phone and call them. You can also ask them for their phone number at the beginning of the session and get it that way. There are lots of different ways to do this, but you can also make plans that if it goes down, that this is what you'll do. So those are different ways that you can do it. Just a quick side note, I will tell you that a few weeks ago, I was doing a visit with a family, and my resident went in first to the video visit, and he's texting me like, there's no audio or video for the patient. And I was like, I'm in a different video visit, right? And I'm like, oh boy. And so anyway, long and the short of it, they figured it out. They called each other, it was all fine. By the time I got in there, I'm a Zoom expert, right? So I was like, I got this, we'll figure it out. Well, it turns out the family really didn't have a webcam. They didn't have any way to video connect with us. But by then they had called in to Zoom. Here's what the family says. They're like, man, I really wish I could see your face. Of course, I'm like, oh Lord. And I was realizing that they're still connected to Zoom. So I was like, well, I can't see you, but you can see me. And so we got back on, and then they were like, there you are. And so you can still do stuff. So if the family wants to see you and that makes them feel better, they can look at your face and you can stare at yourself while you do the visit. You won't be able to see them, but there are all kinds of ways. So again, getting comfortable with your technology really can make a difference for those families. I was kind of cracking up, and my resident sure was cracking up that this family wanted to see my face, but whatever. They wanted to see my face and hear my laugh, which was even funnier, but fine. And so those are things that if that makes a difference for that family or that patient, and that somehow brings them something they needed that day, isn't it nice that you knew how to troubleshoot that technology? So it pays off in the end to know how to do that. All right, so then again, kind of to that point, helping the patient know how to connect. So just having a little basic knowledge about how to troubleshoot things can help. It's not always going to work. Like this family, I didn't realize that they didn't have a webcam, and they didn't have anything they needed on their computer to be able to do what they needed, and that's okay. We made it work. Other things to know is how are you going to handle non-English speaking patients? So what happens? How do you connect through to a translator? This is not hard. It can be done. Again, it's going to be specific. We had that great case last week where we talked about translation, but certainly it can be done. I would encourage you to challenge your system to make sure that these types of patients can still be cared for and still be taken care of, regardless of whether it's a virtual visit or not, but certainly worth thinking about and figuring out how you're going to do it. Okay, so then thinking about specific setting considerations. When I mean setting, I don't mean inside your Zoom account, but I mean your actual physical settings to make a Zoom appointment or a virtual appointment go well. So environment, what's behind you? So right now I am sitting in the basement of my house, and you can see behind me, right? So you can see that I got stuff on my walls, and I have this like curtain behind me, which happens to be a closet, but I got tired of looking at the closet doors. But here's the deal. What if there were personal pictures of my kids? Or what if there were posters of heavy metal bands? Or what if there were who knows what that I might not want my patients to see, right? So you got to think about that. What's behind you? What does that say to the patients? Do you want it to say that to them? Maybe you do, maybe you don't. I don't know, but that's something for you to think about. You can use virtual backgrounds. They're fun, they're fantastic. And yet, again, needs to be considered, whether you're going to use that or whether you're not going to use that. You could use a green screen. I will warn you that they're not as cool as they sound, and they require quite a bit of setup. I did buy one thinking it would be super simple, but it's not. And so fair warning if you set up a green screen, but there's something to think about that. Lighting is also important. You want to have decent lighting so they can see you. If it's all dark, if I were to turn the lights off, you wouldn't be able to see my face at all. And so if I connected with you for a patient visit, that wouldn't feel very reassuring. So thinking about that's important. Same thing with noise. If all of a sudden a patient who can only see this view, right? They're used to sitting with you in a visit and they can see all around them. That's what gives them comfort and understanding that they're not being listened to or, observed by something else. All of a sudden noises start popping in. They're going to wonder, who's in there with her? Can somebody else hear me? So it's important to pay attention to that as well, so that the family or that patient feels as comfortable as possible. Camera placement's important. You really want your face, your head, your shoulders to be in the center of your screen. You don't want them to see the top of your head only. It's pretty funny how unaware sometimes people are about the position of their face on camera. I know people are not terribly comfortable seeing themselves on camera, but you do need to at least look occasionally, because seeing the top of your head, which does happen a lot, is not ideal for your patient when they're trying to do a visit with you. You want to look at the camera. Ideally, the screen is not the place to look, because that's not really what the patient is looking at. So when you look directly at the camera, that's you actually looking at the patient. And then clothing. I'm not a big fan of telling people what to wear. I have worn plenty of crazy patterns on Zoom and it's been just fine. However, technically speaking, you would try to limit your patterns because it's less distracting. And then of course, being professional, as I don't have to tell any of you to be, is important, at least from the top up. And I would encourage you, frankly, I think it's important to just be professional in general. These are kind of no-brainers, but the first part about the environment is definitely something to consider. Okay, so then thinking about, we've talked about, all right, practice your technology, think about those things. Think about how you're going to troubleshoot stuff if something goes wrong. We've talked about your setting. Now, thinking about actual best practices when you get into that visit. So introduce yourself. If they don't know who you are, it's important to do exactly what you would do in any other kind of visit. So, I mean, when I go in to see a patient, I knock, knock, knock. Hi, I'm Dr. Sohl, da, 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 right? So it's important to introduce yourself, especially if they don't know you. Obtaining consent, very important. So this is something that is new to a lot of us, at least for me, and I would imagine most of you. So it's important if you're doing a visit either through telehealth, so video and audio, you need to obtain consent. If you're doing it through audio only, you also need to obtain consent. Most of your institutions or clinics or what have you will have kind of canned verbiage, but I have examples if you need them. Of examples, that you can say, but it's essentially saying, I want to make sure that you acknowledge, so I'm saying this to the patient, you acknowledge that we are doing this and that there are inherent risks such as, potential sharing of information outside of our visit. We will obviously make sure that we protect your privacy as to the best we can, but there are also benefits that you don't have to drive, infection risk is minimized, etc. Right? But that's important that that's not only obtained, but it's documented. So those are important keys as well. Let the patient know that you are in the room alone, and consider moving the camera to show the room. Now, I have not actually done that part because frankly, I'm worried I'd screw up my camera positioning, but you could. And it actually is kind of, again, depending on the content that you're talking about, might be worthwhile. If you're talking about something very sensitive, it might not be a bad idea, because right now you can only see directly behind me. My husband, he's not in here by the way, but he has an entire desk right here, and you can't see my hand either, but you would have no idea if anyone else was in here. And so if it's really sensitive, it might be necessary to take your little camera and just show them that they are safe, that it's private, and that there isn't anyone else there. So those are things to think about. Speak slowly and clearly and at a normal volume. Just because you're on video doesn't mean you have to yell. And so those are important things to think about too. Do not record. Important. This was actually a hot topic on a recent listserv that I'm on, thinking about interesting questions that had come up about maybe research and things like that. Very hot topic on this listserv. Do not record is the take-home message to that. There may come a time where a study might go on and you may gain IRB permission for that, but right now the bottom line is do not record. Limit gestures and distractions. So if you're clicking away and not looking at them, it's no different than in a normal clinic visit. If I'm with you and I'm not looking at you and I'm tapping away, it's not going to feel like I'm paying much attention to you. So same goes here in a virtual visit. Same thing here, don't speak over the patient, let them finish. This is important, especially on a phone visit. So we don't have any visual cue to the family or the patient. Important to really listen and let them finish. Give a little bit of downtime for a pause. So if they have questions, that you give them that space to ask those questions. Definitely an important piece there. And here's my take-home message, frankly, for these best tips and practices. This is what I teach my residents when I talk about using virtual visits. This was both currently during COVID-19 and then in the past. try to engage them as you normally would in person. So I try really hard to just pretend like I'm in the room with them. So I do all the things I would normally do. No, I can't touch them, but I try to engage them just like I normally would, talking about their day, talking about how they are, you know, whatever. If I'm lucky and a cat happens to walk by or a dog is in the background, you know, I get a chance to, you know, peek into their lives and say, who's that, you know, or whatever. It's those kinds of things that allows that family to feel like they're really, that it's no different and that they still get a connection with their provider. So those are things, and I would really encourage you that if that doesn't feel natural, to just keep practicing, because it can feel natural, and it definitely makes a difference to your virtual visit practice. So then a quick point about after the visit, very simple, but you do want to make a clear plan for the family, especially right now. So this goes for always, but right now with this COVID-19, everybody is learning something so new. Your clinic staff, the doctors, the families, everybody's like, what is happening, right? So giving them a clear plan about, all right, we don't know for sure if the next visit's going to be virtual or not, but I want to see you in 3 months. You will hear from our office, you know, et cetera, et cetera, et cetera. Or today I'm prescribing this. I will send it to the pharmacy, you know, like always, or whatever. You need to make it very clear, because right now, and again, that's why I'm emphasizing this, there's so many things changing that you kind of need to be even more explicit. And there isn't anything that they're taking home. They've gotten pretty accustomed, patients have gotten pretty accustomed to depart summaries and various other things. That right now they just need that explicitness, which brings me to my next point. I'm really adamant that we as providers try to encourage patients to enroll in the patient portals that most EMRs are offering. It improves communication immensely, also opens up a much more secure platform for communication between providers, and is a whole lot more efficient than phone calls back and forth. So this is something that you can also do. So what I've been telling families as we make this explicit plan, as I'll say, and don't forget, here, the ones who already are signed up, but the ones who aren't, I'll say, I really would like you to sign up for X. And often I'll show them, because again, I can share my screen. This is how you can sign up. Here's why this is so important. After today's visit, you have full access to my notes. If you forget what I said, which is possible because I talk a lot, then you can go straight to my note and see exactly what we talked about. So you don't have to worry about being confused, right? And so they can see it right then and there. And then I say, and don't forget, then you can also straight away shoot us a message if you have questions or if something comes up. And so this is a really great thing that you can do for families that continues that virtual linkage, which I'm convinced that as we continue to move forward with the benefits of virtual visits, will foster additional usage of these kind of more virtual platforms as we continue to go. So that is kind of it in a nutshell. My take home also, other than just using virtual visits as you would in person, is that virtual visits are really fun. I love doing it. It's really great, actually. And I think the families love it too. I will leave you with this, that I am an autism doctor, and I've had a lot of my little patients tell me that they were made for social distancing and they think it's awesome. And so that's an autism joke. And it's funny for me to see them, and they love seeing me over telehealth because they don't have to come anywhere. So just think about that and embrace kind of these challenges. I know it's not easy to change everything that you're doing, but there are certainly huge silver linings in many ways. So thanks for listening, and I'm happy to take some questions.
Thank you so much. What wonderful information to share. Learn something new every day. So thank you for that. So Joe, do we have questions from our participants?
We do have a couple of questions that rolled in during the presentation. One from David Voren that says, the majority of our patients are actually using their phones for our Zoom visits. Is this what others are experiencing?
Yes. I would say that the majority of, and I don't know if I'm supposed to answer that question, but I would say yes, that is what I'm seeing, as a lot of families using their phones. I've had a few computers, but I think honestly, a lot of people's desktop computers don't have a camera. If they have a laptop, they usually have a camera, but a desktop usually doesn't. So yeah, the phones are what I'm seeing a lot.
Thank you, Kristin. Anyone else want to weigh in on that, what they've been seeing?
And Simon, we noticed that you had answered in the chat you can speak to your response if you'd like.
Yeah, so since we're peds, we have a lot of families who prefer the laptop situation just because it's hands-free. So I can hold my toddler back and with both of my hands rather than trying to hold my phone in front of me. So that's been really helpful. The one thing I pointed out in the chat though that we have run into is since all of our kids are being homeschooled right now, we have a lot of parents who are trying to access various platforms through their children's school issued laptops. And we're seeing a lot of firewall issues with that. So just my 2 cents.
Great, thank you for that information. That certainly is something to think about. All right, Joe, any other questions?
Sure, yeah, next question. Also from David Voren. He says, it's funny about our obtaining consent since we've been talking to patients over the phones for 100 years, and I don't recall ever having to obtain consent for those conversations until now. So this begs the question, to what are we obtaining the consent? That the session will be part of the record and that the patient will be charged for this, or that they're not going to be charged a copay, or that we'll be making medical decisions?
That is an excellent question. Kristin, do you have anything to say to weigh in on that?
I do, mostly laughter. And so, I mean, I couldn't not agree with you more because yeah, I've been doing phone medicine forever and not being paid for it and never obtained consent ever. So I think that's an intriguing question. And I don't know my thinking, and I'd love to hear Robert's thoughts about it because it could be a policy thing. I do wonder if it's about billing for insurance and thinking about, you know, but that's not, by the way, I will read you exactly what we get, how we document this. For the phone visit. Verbal consent for this phone visit was obtained from patient or guardian prior to beginning this encounter. Risks, privacy and security, lack of examination, and benefits, reduced exposure to infectious disease and convenience of using the phone were reviewed and addressed prior to beginning the encounter. So nothing is said about billing, but I definitely do suspect that that's why we have to obtain consent now because we are billing and being reimbursed. So that's a very interesting question that you raised. And I, like I said, I don't really have a great answer for you, but I think it's an amazing observation. Robert, do you know if there's anything of substance behind why we have to obtain consent now for something we've been doing forever?
I believe it's really coming from the idea that we're replacing a medical visit versus before that phone visit would be more related to an encounter that was billed and for which consent, right? They're calling you to say, I need a refill. They're calling you to say, I've got a rash. Do I need to come in? So it is about being billable as well as the clinical decision-making. But that is a very valid point about those telephone visits. I did also want to remind everyone that verbal consent, yes, but you also really should be then getting into the medical record a written consent, that the policy is not verbal and you're done. The policy is verbal to do the service and then written, and that needs to go in the medical record. So there may be a little confusion on that, but written consent is still necessary. It's just not necessary at the time of treatment.
Thank you so much, Robert. Moderator faux pas. I did not have Robert introduce himself at the beginning. So Robert, would you just do a real quick introduction?
Sure, I'm Robert Stiles with the KU School of Medicine, excuse me, I can't even remember. And I also work with the Heartland Telehealth Resource Center and have been spending a lot of time on policy the last few weeks and understanding the major changes in all 3 states as well as at the federal level that are going on and trying to things like verbal consents, right? And telephone visits and lots of things. So yeah, happy to help any way I can.
Thank you so much for that. I know that at least I remembered my name today and I remembered what date it was. It is Earth Day, everyone, if you haven't heard that. So hopefully you can celebrate our nice Earth today, what has less pollution now that we have all been sequestered at home. So that's a great side product, I guess, from coping with this virus. So Joe, do we have any other questions?
We do, but before we move on from that question, just for the benefit of those who can't follow on the chat, perhaps our phone participant, there was another response to the last question from Trisha Harkness in Kansas that says, my understanding is that the consent is to treat via telehealth since it's not typical face-to-face visit. It does appear to link to reimbursement, especially if you're not using a HIPAA compliant platform. It is also to help patients understand the risk. So next, the next question from Sanjay, and if this is the same Sanjay that was on yesterday's session, I think Sanjay Jones is from St. Louis. A question on coding. Any thoughts on coding, specifically difference between G2012 and 99441 to 99443? There have been a couple of responses that have come in via chat for this particular question. One response reads, the G2012 needs to be initiated by the patient, cannot pertain to a visit within the prior 7 days, nor an upcoming one in the next 24 hours. The 9944X code applies to phone communications with patients, and very few payers will reimburse this. When they do, the reimbursement is often paltry. Anybody on the hub team have anything else to add to that?
I do. Sorry, I was just looking up again in my policy document to make sure I understood or got the codes right. I'm not a practitioner, so I don't have them all memorized like every single provider does, right? You never use your code assister. So yeah, it is true that G2012, that's a virtual check-in code. So that does have very specific and different requirements on it. And then looking at the 994 codes, that is the billable code for phones with audio and video. So that would be telehealth as compared to telephone only. I'm sorry, excuse me, I got that wrong. The 99441 through 99443 is the telephone only visit. So that's if you're doing an actual visit without video capability. And the G2012 is a virtual check-in, which let me read really quickly what a virtual check-in is just to make sure everybody understands that. So virtual check-ins allows a patient to talk to a doctor or another practitioner like a nurse practitioner or PA using a device like a phone, integrated audio video system, or captured audio video image without going to the doctor's office. Providers can respond using phone, audio, secure text message, email, or use of a patient portal. These virtual visits will be initiated by the patient. Practitioners may educate beneficiaries that it's allowable. So that's exactly right. The virtual check-in is patient initiated. It's not a visit. And then the 994 codes are, of course, your telephone only without video, not a telehealth visit.
Very good. That stems some other chat in the chat box. Joe, do you want to review those for everyone?
Sure, and thank you, Robert, for digging into the policy on that. A little bit more detail rolling in on the chat, saying the 99441 is for 5 to 10 minutes, the 99442 is 11 to 20, and the 99443 is more than 20 minutes. Also, that Medicare requires you to use the telephonic codes unless you're able to add the video. My goodness, there's a whole bunch of really good information coming in on the chat. Video visits, on the other hand, can be billed using the same E&M codes as face-to-face visit, but must use the telemedicine modifiers 96 and 20. And finally, as usual, reimbursement varies by payers. For example, Medicare telehealth visits, with the exception of virtual communications, must be synchronous audio video, which can include private communication platforms that are not HIPAA compliant. Kansas Medicaid allows televisits, HIPAA compliant audio and video, and telephonic for some codes. Now, there is another question that I don't want to glaze over here in the chat. And it comes from Michelle in Florida. Is there a reliable website for the different allowable codes?
Yes, there is. CMS has on their website the expanded list of codes. You can download it. It's a zip file. It's a little bit confusing because they have 2 Excel documents there. They have the same codes. It's just 2 different ways they presented it. We also have a link to that on the HTRC website and can certainly put it in the box file for today's presentation as well. Just remember, anything like that we put in the box file is not going to be updated as the Fed's updated. So you're better going each time and reconfirming the list. I think they've opened up all the codes they're going to open up for now, but it is possible that they could, as things go on, or they decide there are new codes that need to be done, that they'll add that. So yes, it's on the CMS website, and we'll at least make sure to get the link so you can link and get that Excel document yourself that has every single allowable code and has a column that even tells you if it's a code that's only allowed for COVID-19 or a code that's generally allowable even outside of the public health emergency that we're currently in.
Thank you so much, Robert. Excellent information. Yes, did we have a question? I saw somebody's hand raised maybe, or maybe it was, maybe I'm just seeing things now from Zoom fatigue, right?
We have another question that came in on the coding, Janine.
Okay.
Still confused between when to use G2012 and 99441. Can we provide some clarity on this?
Okay. So 99441 is for telephone only. It's a clinical visit. G2012 is what's called a virtual check-in, which CMS has a group of services that are not considered telehealth. One of those is virtual check-ins. That's initiated by the patient. It's often through the patient portal. It can also occur through another HIPAA compliant system, but it is a very limited encounter with your physician that is not considered a clinical visit and has to be initiated by the patient. So they're just virtual check-ins. If it's not something that you've been doing in your practice, it may be a time to have communication, but probably if you're talking about doing a clinical visit or replacing a clinical visit on the telephone, then you really need to be using the telephone only codes, that 99441 through 99443. I hope that's clear.
Yes, thank you, Robert. Very good. Okay, any others? Okay.
No other questions coming in on chat.
All right.
There was just a question. Which codes do you use for therapy? It was sent to me privately.
What codes?
Which codes you use for therapy, such as behavioral health?
Yes.
And the key there would be to remember that CMS has sort of changed it. You're not doing this the previous way. You don't have to do anymore, the place of service 02 with that. You can now bill those billable codes by practitioners with just the modifier 95. So that's going to get you paid the same as if it happened in your office as a routine clinical visit versus the lower payment, to be honest, that occurred for telehealth purposes using the previous system. So I'm going to make sure that we have the most up-to-date federal policy document in box today, because all of that is hopefully as clearly as possible explained in that policy document, and it's going to be a lot better than what I'm saying verbally, and probably easier to read through. And certainly you can contact HTRC if you have any questions after looking at that document, but all of those types of things are addressed in that. I'm just actually trying to update it because I don't yet have the April 17th changes that happened for rural health clinics and FQHCs that were put out by so we'll get that up by the end of the day and get that in today's session as well. But these other issues have been settled for a little longer. Were addressed last week in our session, and to be also the first Tuesday in May, we will be having another session that will update on policy regulations, as well as the CARES Act and some of the funding opportunities available there. So try to always, as much as possible, return to these types of things and keep you informed, especially as billing and treatment issues change, and we sort of look at changes to the provision of these services over time.
Thank you, Robert. Good advice. Things are changing rapidly and sometimes daily. So yes, please check back at the HTRC, the heartlandtrc.org website, because we try to keep that updated, and we'll certainly update you on these echoes as well. So as Robert mentioned, the FQHCs and rural healthcare clinics have a little bit a different document that you need to look at. And that should be in box as well. So, you know, it's just part of the game, right? Robert will be addressing us not next week, but in 2 weeks about some more updates. Next week, we can look forward to the Technology Assessment Center. That is one of the national telehealth resource centers, and they're going to talk to us and demonstrate some technology, especially with working with patients from home, and how to handle some of those, you know, troubleshooting like Kristin was talking about earlier. So we'll get some more of that, and we look forward to that presentation. Any other questions, concerns?
Janine, we had one more question come in through the chat that's also been addressed with some responses. So again, for the benefit of those not following the chat, I'll read those. The question is, since the Medicare annual wellness visit does not require a physical exam, though weight and BP, can these be billed as telehealth? A couple of responses have rolled in. One saying the required vitals, especially BP, and patient acuity assessment make annual wellness visits challenging, but they are noted as a Medicare code that can be reimbursed as a televisit. And a little bit more elaboration through the portal, asynchronous visits are 99421-3. Annual wellness visits use the same G codes they would be used for normally. Any other clarifications or additions to that?
I would agree that it's difficult. I think it's interesting. Missouri and has allowing EPSDTs, the child, you know, developmental assessments, and that too I think would be very difficult to do through only telehealth, given some of the observations and things that are required. Saying that, my mom has she has dementia, and tomorrow she's having a 4-hour assessment of her dementia done through telehealth. So, you know, hopefully we can make it work when it's needed. And we certainly want to catch kids when there are developmental issues, and the entire point of the annual wellness visit is to catch issues before they become major issues. And that's, you know, Medicare sees the cost savings, but that's also a really positive thing for people to retain their health.
What I know that you have to do for the annual wellness visit is if you may ask them to fill out their health risk assessment, and if they're reporting their weight, their blood pressure, that type of thing, because a lot of people know, or they may have devices at home that they can do that with, but you'll just have to make sure that you document that as self-reported. And then, you know, you can catch up with that the next visit, the next in-person visit that you might have with them. Any other suggestions on that annual wellness?
You actually just nicely summarized some more of the recommendations that are coming in on chat for that.
Let me jump in and talk about the annual wellness visit. It actually works really well on the telemedicine, because you can have them walk around their apartment or house, and you can actually see and document whether they have throw rugs or any of the falls risks and things like that that otherwise you wouldn't be able to really document. So I think telemedicine kind of works really well with the AWVs, because the purpose of those AWVs are to establish future risk that the patient may be at, and looking at the home environment as alone, a huge advantage to doing this that the face-to-face misses completely.
Excellent points. Thank you for that.
Same goes for pediatrics. So on the well child visit, the EPSDT, which is what Robert was mentioning, yes, they're developmental, but they're really checkups where most of them are asking questions, you know, like, does he walk? Does he talk? Things like that. And so just like David just said, you know, that now we actually can see, does he crawl? Does he walk? Does he talk? I mean, yes, we can see some of that in a clinic room that's, you know, 10 feet by 10 feet. But when we actually can see them in the kitchen and see them pick up something and all that stuff, it's actually beautiful. And just a quick side note too about the well child visits, pediatricians are getting darn creative, teaching the parents how to do physical exams, like pretty good ones. And so no, we can't listen to the heart, which is quite important. But there are some, and they can do a lot. And so it's been actually pretty important, and so thankful that Medicaid and some of these other payors have been willing to let us do that, because these kids, again, my perspective, but I also agree that in the in adult populations, it's equally important. This care needs to continue, period. So meaning the preventative visits need to continue. And yeah, I do think that those likely should be in person when this settles, but we're doing fine right now.
Great discussion on the annual wellness visit. I think that's really important for everyone to understand that that can be done. Good job. Any other questions?
And Janine, maybe this will take just a moment to remind everyone that the FCC Telehealth COVID-19 Telehealth Program is available for nonprofit and public institutions. They released that and made their first round of funding last week. But talking about some of the equipment that would be useful to use in the home, whether that's iPads or some of the other equipment that we'll hear about next week, that's a really good opportunity. There's $200 million available. That money will be available either until they run out of it or the end of the COVID-19 public health emergency. So we have information about that as well on our website that really hope that everyone is taking advantage of, especially those working with underserved populations and in very rural areas, and really talking about, is this may become a long-term thing, the type of equipment that's going to make it more possible to take vitals and do these other things that we sometimes struggle with in the current situation.
Thank you for reminding about that money that's out there. Get those proposals in. They're funding right and left. All right. Well, as Dr. Edison taught us on a Zoom that people are experiencing Zoom fatigue, and she says end 10 minutes early so that people can have a breath before their next meeting. So we're going to do that today. We thank you for your attendance. Please join us next week as we look at technology. I think you'll be really pleased with that. Have a great day, and Rachel, have a great birthday.